Well, welcome everybody to today's seminar, and thanks again for attending. Looks like we've got a very nice attendance. Today we have a real pleasure to introduce Professor Tim Dalgleish. So Tim works in Cambridge. He's a clinical psychologist and a professor in the Medical Research Council Cognition and Brain Science Unit in Cambridge. And he's a program lead scientist and also director of the Cambridge Centre for Affective Disorders and an honorary consultant clinical psychologist. So he actually also does do a job in clinical psychology as well as doing all these wonderful things. He has a stellar CV, and I won't go into it in any detail. I would say that his work really focuses on understanding and developing psychological treatments for common mental health problems such as depression, anxiety, and post-traumatic stress, which is what he's going to talk to us about today. And he uses a translation approach which seeks to use insights from basic cognitive neuroscience to enhance clinical interventions for these conditions. And he's used a range of different methods from brain imaging to large clinical trials. And he's incredibly well known. He's part of the Big Myriad trial, one of the leaders of the Big Myriad trial, based in Oxford. And I won't take up any more of your time, but to introduce Tim, and thank you, Tim, for coming, and to welcome you and ask to give you a talk. Thanks.
Thanks very much, Alan, and thanks so much for inviting me to speak today. So a lot of my work is in adults, and so it's a real pleasure to talk about some of our child work, which is very much a collaboration with my more talented colleagues, who I'll refer to as we go through. And so I wasn't quite sure how to present the talk. So what I thought I'd do is tell it in the form of a kind of story, because this was the first work I ever did in my career after, well, even started during my clinical training. So I thought I would start back there with this guy. This is Bill Yule, who was my clinical supervisor on my clinical training back in the late 80s, early 90s at the Institute of Psychiatry. And Bill was one of the pioneers of really trying to understand post-traumatic stress in young children. So I was working with Bill on my child and adolescent placement, and around that time there were a series of quite significant disasters that occurred within the UK. So there was the sinking of the Herald of Free Enterprise ferry in 1987, the Marchioness disaster a couple of years later, the King's Cross fire, and also, perhaps less well known, a cruise ship disaster, which was a school cruise which sank in Greece. And all of the survivors of these disasters came through the Institute of Psychiatry, mostly for reports on legal proceedings. And the whole idea of a post-traumatic stress disorder diagnosis had been introduced into the sort of psychiatric annals in 1980. And so part of the mission was to try and evaluate everybody in terms of this new or relatively new diagnosis. And most of the focus was on the adults, but what we soon discovered was that the children of the families who'd been on these boats and been involved in these disasters had just as many difficulties as the adults. But up to that time, the diagnosis and the thinking around post-traumatic stress was generally that children are completely fine. They kind of take these things in their stride. And there was really no documentation or published work or research at all on post-traumatic stress reactions in children. So what we started to do, and I was very lucky to be there at the beginnings of this, was to start to think about, well, what's the profile of difficulties that these young kids get into, and what can we do to try and help them? And Bill really pioneered that work and was a great influence on me and obviously on many other people. And now, of course, we know that actually by the age of 17, most young people will have experienced a trauma. And by a trauma, I mean a sort of significant life-threatening event that they've either experienced directly or witnessed or been a party to in some way. And until Bill started doing this work, we really had no idea how many of these young kids would develop this diagnosis of post-traumatic stress disorder, which I'm not really going to go into because I think everyone here knows the kind of constellation of problems I'm talking about. So re-experiencing of the trauma through nightmares and flashbacks and physiological reactivity, attempts to avoid reminders through avoiding thoughts and feelings and interactions and cues in the world that make you remember the trauma, along with social withdrawal, sometimes emotional numbing, and even profound amnesia, and then a kind of being on edge all the time, so poor concentration, being very irritable, being very jumpy. So that constellation of approach and avoidance of the event is really captured in this diagnosis. And Bill's work on the Jupiter cruise ship, which you can see here, showed that immediately in the 6 months following the trauma, around 70% of the young people we saw met the criteria for this diagnosis of PTSD. And even 5 years later, this was still around 30%, with, as you can imagine, profound effects on schooling and social and family relationships in the interim. So it seemed that there was something really, really important in trying to understand the nature of these post-traumatic stress reactions in these young people, and critically what we might do about them. And so we really started a framework of a program rather of research, which is still ongoing. And shortly after that, I came to my present department. So I joined the MRC unit in Cambridge in 1994. And I remember I had a 3-year postdoc. So I set out a program of work for my 3-year postdoc, which is essentially the program of work I'm going to talk to you about today. So we're like 26 years later, and I reckon we're probably halfway through the 3-year program of work I set out. So I do remember someone at the interview pointing out that it seemed rather ambitious, but I don't even think even they thought it would take nearly 3 decades to not even finish it. But the idea really was to start by thinking about theoretical ways of modeling post-traumatic stress in this group, and then move on to seeing if we can identify whether those processes we thought were theoretically important are actually different in young kids with post-traumatic stress problems. And then critically, whether they're causally related, as best as we can elucidate causality in longitudinal studies. So do they predict the course of post-traumatic stress over time? And then if they do, can we ameliorate those factors in clinical treatments and then evaluate those treatments through trials? And then obviously try and implement those insights, treatment insights into the NHS. And this is really the MRC's framework for developing complex interventions. What it doesn't say anywhere in this MRC document is that it takes decades to go through this trajectory. So just a warning there for anyone who's still at the beginning of this process. So we started with a whole bunch of theoretical papers and ideas, some of them presented here, and very much influenced by the work of David Clark and Anke Ehlers in Oxford, who are, again, really strong mentors for all of us working in this area. In fact, I was lucky enough to have David as my undergraduate tutor for abnormal psychology, as it was called then, when I was an undergraduate at Oxford. And he was just very inspiring tutor to have. So I used to get to talk to David for an hour every week about my ideas and his thoughts on them. And now if I wanted an hour's appointment, I'd probably have to book 6 months in advance. So I didn't realize how lucky I was back then. So this paper in the middle, anyone who's read that deserves some kind of medal. I wrote it, and even I don't think I could get the way through it. So it's a massive tome trying to pull all of these ideas together. So good luck to anyone who wants to attempt to read that. But it does kind of summarize our thinking at the time we started on this journey. But it all boils down really, the theory, to what I'm going to call here, just for convenience, the 3 M's, which is that a key thing in understanding the young people and indeed the adults who struggle following a trauma is the way the traumatic memory is encoded and laid down. So in essence, the idea that it's somehow preserved and disaggregated from the rest of autobiographical memory and is in a self-contained sort of easily activated set of memory representations, which then intrudes in the forms of nightmares, intrusive thoughts and memories of what happened. So that kind of consolidated, heavily centrally laden memory that can be relived as if it's in the moment is a key part of the problem. Another key issue is the meanings that are projected by the child or the adult onto the trauma. What does it mean that this happened in terms of a broader understanding or a broader representation of the self and the world? And some of these meanings we think are absolutely critical to distinguishing kids who are going to be okay and kids who go on to develop a lot of difficulties. And the final thing is the management. How do you cope with these very preserved intrusive memories, these very scary thoughts and appraisals and meanings? And a lot of that revolves around avoidance and safety behaviors, as you might expect from a general CBT approach. So the idea is that these three M's are critical in understanding what's going on. And this very much comes from the work of David Anker and our early theoretical ideas. So the next thing after the theory really is to say, well, if the nature of the memories is important, if the types of meanings are different and important, if the ways of coping are important, we should be able to look at young people with a diagnosis of post-traumatic stress disorder and kids who've been through the same events, the same traumas, but who seem to be okay. And we should see that they're very different on those three M's, those different things. And we did a whole lot of work on this, and I'm not going to go into all of it, but I'll just give a few examples. So these experimental and cross-sectional studies would involve questionnaires and also laboratory tasks to try and really map out what is different in terms of these three M's between kids with PTSD and those who seem to be okay. And this is work I've done all the way through with Richard Miser-Stedman, who's now at University of East Anglia, and Patrick Smith, who's at the IOP, and they've been the most fantastic colleagues. And this is really work that they've led. I've just been privileged enough to join them in this journey. So one example was a study we did about 10 years ago now that Patrick took the lead on, and was written up by Claire Salmon, who was a student we were working with. So what we did here is we recorded the narratives of children and young people around their trauma, and we coded those narratives for how much they represented these kind of consolidated ring-fenced trauma memories that were very full of sensory details, full of affect, much reduced kind of verbal analysis. How much could we pull that out from the stories that people told of what happened to them? So we got young people to talk about their trauma, but then also other negative events that they experienced. And we got independent coders to go through these narratives and code them for these various features I've just talked about. So what you can see here is, this is actually in the first month post-trauma. So these are young people with acute stress disorder. So they're talking about something that's happened very, very recently. And it's about their traumatic memories versus an unpleasant event, which from objective raters was matched in terms of its negativity and negative impact. And what we've got on the y-axis is an index of memory coherence, or poor memory coherence, on a scale of 1 to 7, which was unanimously agreed by our different raters. And you can see that in the young people with acute stress disorder, there's a marked difference between the poor coherence of the trauma narrative versus the matched event, whereas that's just not the case in the kids who'd had very, very similar traumas but didn't have symptoms of acute stress, which are very similar to post-traumatic stress. So this is sort of the sort of study we were doing to reality check the idea that there is something different about these memories, which you really notice clinically, but you really want to be able to, in a more objective way, validate it in the lab. So moving on to the second M, meanings. So the thing that really is most noticeable when working with young people clinically is the sorts of things they say about what the trauma means. And if you think about the framework that particularly very young children bring into a traumatic event, their understanding of the world is very, very nascent, and the nature of these events has a much more profound impact on how they understand everything about themselves and everything about the world, because it's such a significant event relative to their experience. Whereas I think in adults, there's obviously a much broader understanding that traumas happen and what they are and so on. So you very frequently get young people say, I've obviously gone crazy. I'll never be okay again. I'm permanently ruined. I'm permanently damaged. Nowhere is safe. No one can be trusted. Everything's terrible. And they really, really profoundly believe these things. But often they're not talking about them. So no one's really correcting them and sort of engaging with this dialogue at all. But it really comes out once you start to talk about what happened. So what we did is we developed a measure based on an adult measure, which is called the Post-Traumatic Cognitions Inventory. So we developed a young person version, which you can use down to sort of 7 years old, which has these two subscales. So a fragile person in a scary world was one, we called it, and the other is permanent and disturbing change. And they really capture these kinds of meanings. And we just use this as a questionnaire measure to try and get a metric of these meanings in the young people we were working with. So this is just an idea again of some of the data we were collected. So this time it is young people with a diagnosis of PTSD. Again, young kids who've been through the same trauma but don't have PTSD, and significant differences on this permanent disturbing change subscale, 6 months post-trauma, and again on the fragile person subscale. And we've now got this data from many, many different samples. Another thing we did was more recently is just look at the relationship of these meanings with the symptoms of PTSD. So this is a network analysis, and I don't know how familiar you are with this approach, but it's an approach that's come out of Dutch mental health research, which really is saying we need to look at the relationship between individual symptoms rather than just diagnoses per se, and how those symptoms drive each other. So you might imagine that if you've got poor sleep and nightmares, then you're likely to have poor concentration the next day and feel more tired. So the idea that symptoms are interrelated, and that's a key thing we need to understand to drive treatments. But what you can also do is add in other measures into these networks. So here we've added in the blue these different items from the post-traumatic cognitions inventory for children. So these different meanings. So my life will never be good again. I can't trust anybody. I'll never be able to cope. Bad things will always happen to me. My life has been destroyed. I've gone crazy. And what you can see here with the PTSD symptoms in red and the depression symptoms in green is that just how integrated these meanings are with these different symptoms. And I think that's the key thing that we really noticed come from our early clinical work, the absolutely central role that these meanings seem to play, which of course in adults is no surprise, because many of us have a very cognitive approach, but in these young people was much more of a surprise. And we did a whole load of other studies on core cognitive processes using lab tasks, memory bias, inhibitory processing on the Stroop, dot probe task, judgments, and there's actually a whole bunch more recently as well, but I'm not going to go into those. But we're really trying to map out the cognitive domains that were impacted by these 3 M's, the types of meanings, the types of memories, and the downstream cognitive results of being in that mindset. And we also did a lot of work on the 3rd M, the maladaptive coping, but I think that's much more of a mainstream part of CBT that we understand. And of course, it's a key set of symptoms within the PTSD constellation, the sort of avoidance and safety behaviors. So I'm not going to talk too much about that in the interest of time. So it's all very well showing that if you get a group of kids who meet criteria for a diagnosis or seem in a great deal of distress and are attending at a clinic, that various aspects of their psychological functioning seem quite different. It's a different thing to say, well, those things are critical in driving the onset and maintenance of problems. And for that, you really need to turn to longitudinal studies. And we've done a bunch of these. And I'm just really going to talk about the take-home message. So they all follow the same kind of format in that we've done some at the Institute of Psychiatry and King's College Hospital, and we've done some at Adam Brooks Hospital in Cambridge. We work with A&E consultants and A&E departments and introduce ourselves to families when shortly after they've attended for a traumatic incident to the emergency room. And then we follow those young people and their families up for 6 months or a year or even longer. And what we're trying to understand is, are these key factors, the meanings and the memories and the ways of coping, when we measure them early on in this trajectory, are they the things that are driving the onset and maintenance of symptoms over a year or 2 years? So the early ones, we did 6 months, and we've just finished actually a 4-year follow-up of some very young children. But the bottom line is that sure enough, the dysfunctional appraisals, these maladaptive meanings I've talked about, the poorly coherent sensory laden memories, and these maladapting coping styles all independently predict the course of PTSD over and above initial symptoms. So this gives us a real sense that these things are absolutely key in driving the problems in these young people. And that's important because that means we've got a place to start when thinking about how to develop our interventions. Interestingly, very different to adults, where trauma-related and demographic factors are important. So how severe was the trauma? Did you end up, for example, admitted to hospital for a month? Did you have a coma? How much badly you were injured? Did people die? And demographic factors like being female or previous experience of trauma or psychiatric history, they seem to have very, very little impact on the course of post-traumatic stress in children and young people. It's very much driven by these cognitive and psychological factors. So that's a real difference between adults and younger trauma victims. And we also have come to realize that these 4 trajectories, which I don't think will be a surprise, there are some kids who have a persistent trajectory. So they have a lot of distress really from day one, and it never goes away. There are some kids who seem fine right from the beginning, as far as we can tell. So although they've had this very, very awful event, they seem very resilient. There's quite a lot of kids who have a natural recovery within the first 2-3 months. So there's quite a lot of symptoms, but they gradually assimilate their experience into their previous sort of understanding of the world, and the symptoms go away. And there's a very small number who are okay for a while, but then develop problems a bit later, often around a major life change, like changing schools or something like that. So we kind of had our theory. We identified these 3 M's, these 3 key components. We showed that they were really quite markedly different in kids who've got post-traumatic stress, and that they seem to be driving symptoms. So the next key thing is, well, what can we do about that? So the treatment ideas were very much influenced by David and Anka's treatment in adults. And they really are simply trying to target those 3 M's and help children and families to develop ways to change the memories of the trauma and restructure them, challenge and understand where the difficult meanings come from, and let go of maladaptive coping strategies and replace them with more functional coping strategies. So a very generic CBT approach, but also very, very cognitive, which is different to traditional approaches to post-traumatic stress, even in adults, where it's a lot more behavioral and exposure based. So these interventions have much more minimal emphasis on exposure. So there's a little bit of exposure work, a little bit of reliving of the trauma, but it's really quite a cognitive approach, which is a real challenge when it comes to working with the youngest kids, aged 2 to 6, which I'll come to in a bit. So we're really trying to focus on these things, which are critically all tractable and changeable. So I think someone once told me that the hardest thing in developing interventions is really not working out what's going on, but what things you can really, really change and which things are really causal. So the sweet spot is to find something that can be changed and that's actually causally driving problems. And it's quite hard to elucidate exactly what those things are, but we're really confident that these 3 M's are at least 3 of the things that fit that bill. And actually, Patrick and David and Bill and another colleague, Sean Perrin, have put all of this together in this book, as part of the CBT with Children and Adolescents series. So this is the first trial we did, which Patrick led, which is about 15 years ago now. And so what we've got here is our trauma-focused cognitive therapy that really targets these 3 M's. And this trial was against a waitlist control condition. And we've got child's post-traumatic stress symptom scores here, pre, post, and at 6-month follow-up. And you can see a really, really marked effect of the treatment on getting rid of symptoms, which is maintained over 6 months. And a little bit of natural recovery in the waitlist group, but very, very, very little. And if we don't have follow-up there because these kids crossed over and then received the treatment. So this initial trial really gave us confidence that this very cognitive approach, which you can use with adults, is actually also something that has real traction in children and young people. So we also realized from our longitudinal work that there's no real point in trying to do anything in the first few months post-trauma, because there's this big natural recovery I referred to. So this first trial was any time after the trauma, so it was really chronic problems. But we also then did a subsequent trial just in this acute phase between 2 and 6 months. And again, we get very, very similar effects as essentially an early intervention, the earliest that it makes sense to intervene. And this time we did a follow-up up to a year. And we also did some mechanisms work to show that the reduction in post-traumatic stress symptoms as a function of whether you got the cognitive therapy or the wait list was really driven and mediated by a change in appraisals. So this is just the old Barron and Kenny approach. So you can look at the relationship between whether you get the cognitive therapy, whether you get the cognitive therapy or the, how much that improves symptoms. So that's the graphs I've just shown you. And then whether you get cognitive therapy or waitlist really affects the change in appraisal. So we only get the change in these meanings across treatment for those kids who get the cognitive therapy. And the amount the meanings change is highly related to the improvement in symptoms. And when you add that indirect path in, it reduces the strength of this direct path. So this is evidence that not only is the cognitive therapy successfully reducing the symptoms, but it seems to be working by changing these meanings, which is a core focus of what we're trying to do in the therapy. So I wanted to talk now for the last part on very young children. Historically, the PTSD diagnosis has been unchanged since it initially came in terms of the developmental sensitivity required. So all of the work I've just talked about really conceptualized PTSD in the same way that you might think of it in adults. But what soon became clear is that in the youngest of children, as you might imagine, they don't really manifest their post-traumatic stress in quite the same way. And this was really sort of brought to the attention of the world by Mike Shearinger about 20 years ago. He's an American psychiatrist. And what he did was work with preschoolers and infants and show that the DSM-4 diagnosis, as it was then, and even the DSM-3R, I think some of his early work, he showed that there was absolutely no very young children between the ages of 2 and 6 who met criteria for that diagnosis at all. So he developed what he called an alternative algorithm, a different set of diagnostic symptoms, but also a different way of clustering them in the diagnostic algorithm. So focusing much more on things that could be observed, like disruptive play, reverse developmental milestones, and away from things that required quite sophisticated psychological insight, like a sense of foreshortened future or amnesia or emotional numbing. And he also reduced the number of avoidance symptoms that you would need to see on the basis that very young children often don't have much control over whether they avoid things or not. They're just carted around by their parents. And he with a really influential case series showed that if you change the algorithm, it didn't change the number of symptoms, and it didn't change the clinical severity or any measures of difficulties in functioning. It was just a reorganizing about how you looked at symptoms. You then saw that there was actually a large number of kids who met criteria for this alternative PTSD algorithm. So we early work, we did a study with our kids who we were working with an A&E of the same kind. So here you see that these are the older children, 10 to 16 years. This uses the DSM-4 PTSD criteria, and about 12.5% meet criteria for PTSD following a trauma in an emergency room. These were either violent assault or road accident kids. But actually, when you go down to a very young age group, it's less than 2%. But what happens when you apply the alternative algorithm is that you go up to around 10%. So this algorithm really brings the estimates of how many kids are struggling with post-traumatic stress at a clinical level in this age range up to the same kind of levels as you would see in older kids. And now, of course, this algorithm is instantiated in the DSM-5 as a preschool subtype of PTSD. So this work, Mike Scheringer's work and our early work, has at least had the benefit of changing the diagnostic criteria, which in the UK isn't such a big deal, but in America, where unless you meet criteria, you don't access health insurance, is actually really important. So we've now done quite a bit more work on this. In fact, we've just completed a meta-analysis of all of the prevalence studies, of which there's now been quite a lot. And you can see that, there's a mixture here of these alternative algorithm studies and ones that have used the DSM-4. And the DSM-4 ones show generally much lower prevalence rates, whereas the prevalence rates range from 20 to 50, 60% when using the alternative algorithm. And these are a whole range of different trauma-exposed samples. Some of them are clinical, some of them are more community samples. And we've just actually completed the first epidemiological study looking at this alternative, developmentally sensitive way of understanding post-traumatic stress in young kids. So this is the National Survey data of mental health of children and young people, so 1999 and 2004 surveys combined, where the DSM-4 PTSD was diagnosed through a clinical interview, but we had sufficient questions and items from the interview to also do this alternative algorithm approach. And so the data obviously show much lower prevalence rates, but what we've got here is the DSM diagnosis, how many kids meet criteria according to the DSM-4 and how many meet criteria according to this alternative algorithm. And you can see that in the national survey data, not a single child under 10 met criteria for PTSD according to the DSM, which is quite a shock to us. Though Mike Scheringer's initial study, as I said, found no children, but he was looking at 2 to 6-year-olds. But we found no children in the national survey met DSM criteria for PTSD until they got to 11, where it went to 2%. Whereas when you apply this alternative algorithm, you're getting lower numbers than we've got when we're following up people in the clinic, but that's because it's a community epidemiological sample, but around 5-6% of the younger kids meeting criteria for PTSD. So this really shows that for identifying these problems, you really need a developmentally sensitive way to evaluate them. It's even more stark when you look at children who are at high risk. So this is another epidemiological study we've just finished on the National Survey of Looked After Children in England and Wales. So obviously fewer children, thank goodness, 1,500, but still a large sample. And the data here were really shocking. So we do get some small percentage of children meeting criteria for PTSD using the DSM. But if we look at these youngest children, it goes from 2% to nearly 60% of kids meet criteria for clinically significant post-traumatic stress problems, depending on the way you think about how those symptoms might be organized. And that's a 30-fold increase in prevalence. And we were really shocked about how stark these differences were once you move to a vulnerable population. And there are other differences in the nature of symptoms in these very, very young children, which I'll just go through quickly. So we also looked at the factor structure. So this is how much do the symptoms constellate into the DSM-4 clusters of intrusion, avoidance, cognitions, and hyperarousal. Or how valid is the new DSM-5 preschool PTSD clustering? And you don't really need to go into the details of these different model fits, but the key thing is that in young children, this new conceptualization of a developmentally sensitive preschool version of PTSD fits the symptom data much better than the old DSM-4 data. So some validation that this, in terms of the factor structure, that this new way of thinking, which has been entirely derived from the clinic, is actually more psychometrically robust. And more recently, we've also looked at these networks. We saw one earlier involving post-traumatic cognitions, but this time we've just looked at the relationship of the symptoms themselves. So this is on about 500 kids up to the age of 6, and about 1,000 kids between the ages of 6 and 12. And you can see in the very young children, so this is under 6, that really these are the symptoms of PTSD. So the intrusive symptoms are the B symptoms. So symptoms of psychological and physiological reactivity and associated avoidance of feelings and situations and emotions are the key cluster of symptoms which all relate together. So these edges are essentially partial correlation weights, and the thicker the lines, the stronger the relationship. So really it's saying that the constellation of symptoms which all drive each other in young children are around this hyper reactivity of thoughts, feelings, and physical sensations, and the avoidance that it engenders. Whereas in older kids, this cluster is actually quite weakly interrelated, and it's actually much more around hyperarousal and being on edge, poor sleep, irritability, often conduct problems and acting out, and nightmares. So even just looking at the patterns of the symptoms themselves, and these are still pretty young children, these are 6 to 10 or 11-year-olds, the nature of the interrelationships of the symptoms is quite different. So a emerging picture that in our very youngest trauma survivors is quite a different presentation, not just in terms of where you organize the PTSD symptoms for a diagnosis, but also about how those symptoms relate to each other and how they disaggregate in terms of factor structure. So I just finished with a little bit on treatment. So the challenge really was to try and take the same ideas that we used in our older kids to develop a treatment for these very young children. So we developed a treatment manual based on the older child manual, which is shown here again, and again tried to focus on restructuring the memories and the meanings and the maladaptive coping, but obviously trying to use clinical techniques and methods that are much more suitable for young children whose verbal skills are very, very limited. So it's a 12-session intervention. I won't go into too much detail, but anyone who works in CBT will realize these are many common components. So some kind of activation and getting kids back to doing what they used to like doing. And then a lot of work on this cognitive restructuring, and some exposure work, and then a lot of work on coping, and all the way through, of course, working with the parents. And most of the cognitive restructuring work is done through drawings and play and music and drama. We don't sit down and say, right, let's construct your trauma narrative, which we do a lot more with the older kids. We would work on iPads and add in new meanings to try and counteract the old meanings within the trauma narrative. So here it's normally done with storyboards and pictures. So this is a little girl I saw right at the beginning of our development of this, whose mum had been run over and was trapped under the wheels of a car and was screaming, and these are the little girls, and this is the driver of the car, who's 15 times the size of everybody else, so someone they didn't know, and this is their picture of what happened. And another thing you get to do, this is the best bit about working with these young kids is you get your grant, and then you get to go down to the toy shop and buy loads of stuff from Playmobil to play and construct trauma memories. And rather alarmingly, Playmobil has everything you need for your average trauma memory. So here's an ICU setup. There's a whole ambulance thing that you've got with accidents, and lots of animals. Lots of these young kids have been bitten or attacked by animals, so it's always good to have. And so you can do lots of play, building up these scenarios and photographing them. So it's a really quite a nice way to interact with the kids. I mean, Playmobil actually gets much darker. They even have a Grim Reaper, which is terrible, which I thought was shocking until someone pointed out it was actually supposed to be a Halloween costume. They're not really trying to represent death. But anyway, we didn't get the Grim Reaper. So we put together our intervention. We got our manual. We did our case series, and then we we got a grant to do a proof of principle trial, which we've only just finished. So this compared this cognitive therapy for post-traumatic stress to treatment as usual. In fact, we went up to 8 years rather than 6 years because of the data I've just shown you, showing that these younger children that even up to 8 years have these very, very different constellation of symptoms. And this is our initial data we've just submitted for publication. So this is our cognitive therapy, and you can see at the end of the intervention, around 80% of our kids no longer met criteria for this developmentally sensitive diagnosis, whereas in treatment as usual, which in certainly where we are in CAM services, is they do get some help, but it's very few kids get anything that's really focused around their trauma. So most of the kids who had treatment as usual still had PTSD at the end. Only 7% had lost their diagnosis. So that's where we're at. We've I think begun to understand the nature of PTSD and post-traumatic stress in these very young children, how it's different. I think we've got an intervention which shows promise, and we're just now applying to do a full-scale efficacy trial. It feels like there's a long way to go, given that at the beginning I thought this was just a 3-year program of work, and I'm wondering if I'll ever actually finish it. One thing I would like to say is I actually really embrace a transdiagnostic approach to mental health problems. So I've talked very much about PTSD here, but a key part of all these interventions is understanding that this is just one part of a much more varied and heterogeneous response that kids have to trauma. And I've really not talked very much about that, just to make things a bit easier. So to summarize, I've tried to present a translational program of work in terms of a story, where we started with our theory, how we built the interventions, how we tested them, and where we're at now. And I think we've got good evidence that these 3 things are key in understanding post-traumatic stress in young people. They're not the only things, but they seem really important. And I think I've shown that when you're dealing with the very youngest children, you need to throw the standard diagnostic PTSD type approach out of the window and start by thinking about exactly how these problems manifest and interact with each other in our youngest children, and develop your treatments accordingly. And we've got a bunch of trials. I haven't talked about all of them. Prospects and Decrypt are actually on kids who've had chronic repetitive traumas like domestic abuse, sexual abuse, domestic violence, which we're doing as well, which Richard's leading. I haven't talked about those. And also other work we've done showing that these treatments are actually very cost effective. And another big project that Patrick's leading, Optic, which is developing an e-therapy version with David and Anka to use with kids from 8 to 18, which is, the trial's just started. I think we've recruited 3 people so far. So just like to thank all of my fantastic colleagues, but especially these guys who I've mentioned many times, but a whole load of other people, and our various funders. Thank you for listening.